Welcome back to Roadmap to Residency. Today we are attacking outpatient infections, one of the highest yield clusters on Step 3. We are covering upper respiratory illness versus bacterial sinusitis, bronchitis, skin infections, and sexually transmitted infections. We are not reteaching microbiology. Your question bank already does that well. We are showing you how these stems are built and how to spot the answer fast. Here is the plan. First, find the 2 or 3 words in the stem that decide the whole question, and that is almost always a timeline or a red flag. Second, expose the traps, including the purulence trap, the mucus color trap, and the patient who demands antibiotics. Third, walk 4 stems and explain why every choice is right or wrong. The content lives in the infectious disease and outpatient sections of your review resource. Watch this for strategy, then go earn the knowledge doing questions. Strategy 1. Find the timeline before anything else. In a stem about facial pressure, congestion, and drainage, hunt for the duration. Under 10 days and not severely ill means viral upper respiratory illness, and the answer is supportive care. 10 days or more without improvement means the test is handing you bacterial sinusitis. The number of days is the question. The second trigger is the patient who got better and then got worse again, or who has high fever with severe facial pain from the start. Either flips a viral picture to bacterial before 10 days. Circle the day count, and the word worsened every time. Here is our first stem, a 30-year-old woman, 6 days of nasal congestion, facial pressure, and thick green drainage. Temperature normal, comfortable. She says the green color means she needs an antibiotic, and she has a wedding coming up. Nasal mucosa boggy, lungs clear. Most appropriate next step. Notice how much of that is emotional noise designed to push you toward a prescription. Find the number. Find the fever. Step 1. Strip the noise. 6 days, no fever, comfortable. That is viral, full stop. The green drainage is the color trap, and it is one of the most reliably tested distractors in outpatient medicine, because color reflects white blood cells, not bacteria. The wedding and her request are patient pressure written into the stem to see if you cave. Step 2. Apply the rule. Under 10 days, not severe, no double worsening means supportive care and reassurance, with return if she does not improve. Step 3. Eliminate. Amoxicillin with clavulanate is wrong because she meets no bacterial criteria, and prescribing to satisfy a patient is always wrong here. Corticosteroids are not indicated. Computed tomography of the sinuses is the overkill answer and changes nothing. The answer is supportive care. Strategy 2. The cough stem, where the antibiotic reflex kills scores. The classic stem gives a cough lasting a couple of weeks, sometimes after a cold. But look what else it gives you. Normal vital signs, clear lungs. That combination means no chest radiograph and no antibiotics, because bronchitis is overwhelmingly viral. The moment the stem hands you fever with fast breathing, a fast heart rate, low oxygen, or focal crackles, you are in a different question and imaging is appropriate. That switch is what is tested. And expect the pressure, because these stems always include someone wanting antibiotics. That is bait. The tested skill is counseling, and often the correct answer names the conversation rather than a drug. Second stem. A 45-year-old man, 12 days of cough with yellow sputum that started after a head cold. Some chest soreness from coughing. No shortness of breath, does not smoke. Temperature, heart rate, breathing rate, and oxygen saturation all normal. Lungs clear. And he wants the antibiotic that worked last year. Most appropriate next step. Let the vital signs do the work for you. Read the vital signs first, because the stem spent 4 clauses telling you what you need. Everything normal, lungs clear. That is the writer explicitly ruling out pneumonia for you. Yellow sputum is the color trap again, and 12 days is normal, because this cough commonly runs 2 to 3 weeks. So why is counseling the answer? Here is the mindset shift. Telling him the cough can last 3 weeks is not a consolation prize, it is the treatment, because it stops him coming back demanding antibiotics. Azithromycin is wrong, bronchitis is viral, a radiograph is unnecessary with normal vital signs and a clear chest. An inhaled corticosteroid has no role without asthma. The answer is symptomatic care and counseling. Strategy 3. Skin infections look sprawling, but nearly every stem sorts on one question. Is there pus or is there not? A fluctuant, drainable collection is an abscess, and drainage is the answer even when a drug also appears on the list. That trips people constantly. Spreading redness and warmth with no collection is non-purulent cellulitis, and coverage aims at streptococcus. Second, watch for the coverage word. Intravenous drug use, a wrestler, a prior resistant infection, or a recent hospital stay means cover-resistant staphylococcus. Absent those words, do not reflexively broaden. Third, find the admission trigger. Admission needs systemic illness, rapid spread, failed oral therapy, or an immunocompromised host. And pain out of proportion with sick vital signs is a surgical emergency, not a prescription question. Third stem. A 28-year-old healthy man, 4 days of a painful lesion on his thigh. Examination shows a tender, fluctuant nodule about 3 centimeters with surrounding redness and no streaking. Temperature and vital signs normal, no diabetes, no medications. Most appropriate next step. There is one word in that examination that decides the entire question. Find it. Spot the pattern. The word fluctuant is the whole question. Fluctuant means a drainable collection of pus, so this is an abscess, not cellulitis. He is well appearing with normal vital signs and no diabetes, so nothing pushes you to escalate. Apply the rule. For a drainable abscess, the answer is incision and drainage. Source control is the treatment, because an antibiotic alone cannot cure a walled-off collection of pus. Eliminate. Cephalexin alone fails twice, since it neither drains the pus nor covers resistant staphylococcus. Admission for intravenous vancomycin is the overkill trap for a well man. Warm compressors delay definitive care. The answer is incision and drainage. When the stem says fluctuant, reach for a scalpel, not a prescription pad. Strategy 4. Sexually transmitted infections. This topic has a distinct personality, and once you know it, these get much easier. First, do not wait for results. When the presentation fits, you treat at that visit rather than waiting for confirmation because the patient may never come back. Any choice that says await results before treating is almost always wrong. Second, look for the second task. These stems rarely have one correct action. The writers hide a second job in the last lines, usually treating the partner, testing for other infections including the human immunodeficiency virus and syphilis, or reporting to the health department. When two choices both treat the patient, the one that also protects the partner wins. Final stem. A 22-year-old man, 3 days of burning with urination and purulent penile discharge. New partner, inconsistent condom use, temperature and vital signs normal. Discharge at the urethral opening, no testicular tenderness, no rash. Testing for gonorrhea and chlamydia is sent. Most appropriate next step. Remember the 2 habits. Do not wait and look for the second task. The presentation fits. Purulent discharge with burning in a young man with a new partner is urethritis, and that picture alone is enough to act on. Empiric treatment covers gonorrhea and chlamydia together, because co-infection is common and you cannot count on him returning. Now the distinctions. Awaiting results is the wait-and-see trap. Wrong, because he may never come back. Treating for chlamydia only leaves gonorrhea untreated, a tempting half answer. Cystoscopy referral is the overkill trap. Only one choice both treats presumptively and addresses the partner, which is that hidden second task. The answer is treat now for both and address partner treatment. Let us pull this together into one exam day pearl, the 2-word scan. Before you read a single answer choice, find 2 things. How many days, and are the vital signs normal? Those 2 data points decide most of these questions, and the rest of the stem is usually there to distract or pressure you. Then scan for the planted words. Fluctuant means drainage. Worsened after improving means bacterial. Green or yellow means nothing. A patient asking for antibiotics means the answer is counseling. New partner means treat now and treat the partner. These words are placed on purpose. See them as signals rather than story, and these become the fastest points on the exam. That is outpatient infections. Under 10 days and not severe means supportive care, while 10 days or double worsening means bacterial sinusitis. Normal vital signs with a clear chest means no antibiotics and no imaging, and counseling is the treatment. Fluctuant means drainage. And with sexually transmitted infections, treat now and find the hidden second task. For the content, go to the Outpatient Infections and Infectious Disease sections of your primary review resource and drill the matching question, bank blocks under timed conditions. Read every explanation, even the ones you got right, because that is where these patterns live. Visit roadmaptoresidency.com for expert tutors and residency advisors who can build you a personalized study plan. If this helped, please like and subscribe so you do not miss our next session. Good luck on your exam.